Good afternoon, ladies and gentlemen, and welcome to our Cut-Crismo Partnership Workshop. And we would like to welcome everyone present here, both online and here in the Japi Van Lille Auditorium here at Central University of Technology. This is our first workshop with Crismo in partnership with Central University of Technology. And the theme for this workshop is a partnership to develop clinical research collaboration and opportunities in the Free State region. Ladies and gentlemen, let me request that we observe a moment of silence before we can start with our program. Thank you. Thank you very much, ladies and gentlemen. My name is Boipelo Nagedi, the Faculty Administrator in the Faculty of Health and Environmental Sciences here in the Central University of Technology in the main campus, Bloemfontein. We would like to take this opportunity to once again welcome everybody. And in our program, I will go straight into our program. I would like to call Dr. Hilda Mfengwana to come and do the opening and welcome to our workshop.
Thank you so much, Boipelo, for the introduction. Good afternoon, ladies and gentlemen. It is a pleasure to welcome you all on behalf of the Faculty of Health and Environmental Sciences at CUT to the to the CUT Crismo Workshop and Information Sharing Session on Clinical Trials Management Research. A warm welcome to our guests from Crismo and the CUT Department of Health, as well as the Free State Department of Health, as well as our CUT staff members and students that are part of this session. I would also like to extend our warm welcome to all attendees from other institutions, both that are in this venue and on the virtual platform. Today we will be getting some insights into the clinical research opportunities and the South African perspectives on clinical research. We actually look forward to engaging with everyone in this exciting session. Thank you so much. Welcome.
Thank you very much, Dr. Mfengwana. We take that all our participants have been warmly welcomed. And I would like to call upon Professor Tshepiso Makafula, who will give us an overview of this partnership. Prof. Makafula, you're welcome.
Thank you very much, Boipelo. Good morning, colleagues. I will be giving a brief overview of the partnership and initiatives today. Mine will be a very short talk to allow for colleagues from Crismo to actually give us the in-depth into the clinical trials management research and opportunities that may be available. I'm trying to share. Technology is dealing with me. Do I share first or screen? I share first. Okay. Fantastic. Thank you so much. Then you can minimize. Okay. So as an overview for I think the letters are not in order, but yes, exactly that. And they are in partnership with CUT, in particular the Center for Quality of Health and Living, based in the faculty Okay, colleagues, it looks like we are back, and our apologies for that. We had a little technical situation. As I was saying, this is a partnership between CUT, in particular, the Center for Quality of Health and Living in the Faculty of Health and Environmental Sciences, together with Cut-Crismo, which is Clinical Research Investigator Site Management Organization. So this partnership will be focused on enhancing and facilitating interdisciplinary, multidisciplinary, and transdisciplinary research collaboration, knowledge transfer, and training related to clinical trials management and big data management. From the faculty side, from the faculty side, we'll be involved in one or more of the projects in the research center. Cut-Crismo has quite a number of research sites, and they will talk about that when they give their talks. But then the faculty will then be involved in any of those research centers and also be active in the Cut-Crismo CUT Academy, which I'll talk about later on. This partnership is also aimed at providing education and training in research and related skills, especially for postgraduate students. We're looking specifically at introducing a master's and a doctoral qualification in clinical trials management and a PGD, a postgraduate diploma in clinical trials management, and thereby enhance academic programs in the faculty. We aim to contribute to the university's strategic educational and research mission and to support synergies between research, teaching, and learning, and also allowing for our students to have direct industry exposure during their research years or their student years at both undergraduate and postgraduate levels, and also transfer and mobilize knowledge gained through research for the benefit of society via a variety of mechanisms as appropriate. So the partnership is these are the partnership deliverables. Of course, we are looking at establishing a clinical trials academy, a clinical trials research center, research projects aimed at both master's and doctoral qualifications, and some of them will be for non-qualification based research, and of course publications. And the research center. The research center, in partnership with Cut-Crismo, will be focusing on bridging the theory and the practice in clinical trials management, and we're also looking at partnering with enterprises to run and conduct clinical trials. To date, the activities, some of which have not yet taken place but are in the pipeline, is to partner with industry for new clinical trials, to support local innovators to deliver research outcomes, to enable registration of devices and medicines, and also looking at traditional medicines needing to be tested to be taken into clinical trials after being proven to be safe in both animal studies. The current ongoing project is on a COVID-19 follow-up study, and details of this project will be shared at a later stage. Now we get to the Clinical Trials Academy. This will be a Cut-Crismo CUT course offering, and we're looking at offering a good clinical practice as a year course. And we'll also be looking at developing a bachelor's in clinical trials management. But what we focus on right now to fast track the first intake, probably in 2023 or 2024, is a advanced postgraduate diploma in clinical trials management, and also a postgraduate diploma in clinical trials, also together with a master's and a doctoral qualification in clinical trials management. This will be the end of my talk, and I will hand over to the colleagues from Cut-Crismo to share the information, in-depth information with us on clinical trials management. Thank you very much.
Question, or will there be questions later on what Prof just said?
Yes, we'll have a Q&A after the next presentation. Thank you.
Thank you, Professor Makafula. We would like to welcome Ntate Major Tindi to the podium. Thank you.
Okay, good afternoon, colleagues. Am I audible? Okay, thank you. Good afternoon, colleagues, and those who are also attending online. My name is Major Gamaqindi. I'm the Executive Director at Cut-Crismo, and thank you so much for that. I'm coming from a company called Cut-Crismo. It's an abbreviation for Clinical Research Investigator Site Management Organization. And thank you very much for this opportunity and the platform to Program Director Buipelo, she's not here, Dr. Makafula for also the overview and opening. Just to take you through basically what we do at Cut-Crismo. Before I get there, maybe I want to share with you our agenda in terms of what we'll be discussing. I'm also a proud alumni, and that's why I'm also wearing my outfit and make sure that I align. And we're going to look at the Cut-Crismo overview and capacity building, which is what my presentation will focus on. And my colleagues, Dr. Sipokosi will look at the overview of clinical research perspective and the South African industry and regulation. We will also have GCP clinical principal investigator role and responsibility by Dr. Fadan, and we will then have our Q&A session. And if there's any other, we will then thank everyone. So in terms of our company overview, I have just mentioned Cut-Crismo is a clinical research investigator site management organization. A site management organization is a model within the pharmaceutical space. And so we are actually a research center that is investigating new medication. I will talk more onto that. Our focus as a company since 2015 has been on what we call clinical research capacity building. And I will talk more about what we mean when we talk about capacity building and how we have been working with different partners to make sure that we develop capacity building. Our clients are your major pharmaceutical companies or your biotech companies, including academic institutions and government institutions. Those that we have worked with, I will share that in a while. I also want to gloat about this one, that we are the winner of the Standard Bank Business Award 2021. We have got the category of we won the category of Rising Star, something we are also proud of. Another point that I want to also mention is that Cut-Crismo is 100% black owned, therefore a level 1 BEE contributor. Within the industry, we talk about our regulator, which is SAPRA. We have been inspected by SAPRA on 2 of our projects or clinical trials. So within the industry, if you get audited, I mean, it's something big. You know, we go out and say that our quality is good, the methods that we are using to collect our data is good, and our processes basically. So the fact that we come out of that inspection without any finding, it gives us the assurance that whatever the work that we are doing, it follows the regulatory and good clinical practice. And then the other part that I also want to mention is that for the studies that we have conducted, we have had sponsor audits. So there's a difference between an inspection and audit. So sponsors would have their audits, and they've audited most of the studies or their studies particularly, but we have come out as well without any critical finding. The last part I wanted to, just to share is that we have to date conducted over 20 clinical trials, and these are global studies. Just to mention a few, we have worked with Johnson & Johnson when COVID hit the world. So we were one of the research centers that participated in the Ensemble clinical trial. It was a randomized controlled clinical study, which was the vaccine for COVID-19. So one of our sites, one of the sites in Germiston participated in this vaccine study. After we have participated in the Johnson & Johnson vaccine study, it was then rolled out to the healthcare workers as an emergency use. So we were part of the rollout, and that particular rollout under the Sisonke clinical trial, I'm sure most of you would know that the Sisonke was a access to healthcare workers, because we were losing a lot of healthcare workers, and because of this, there was no vaccine that was already approved at that time. So as soon as Johnson & Johnson was approved for emergency use, Sisonke clinical trial by the South African Medical Research Council came on board, and we rolled it out in the north of Free State, which was the Fezile Derby district. So Cut-Crismo was responsible for the north side. We are currently working with Sinovac. It's a life science company based in China, Beijing. They are also looking at a COVID-19 study, COVID-19 vaccine for children. This is still an ongoing study. So Cut-Crismo is one of the research sites, the only actually 11 research sites in the country that are participating in this children vaccine, because we don't have a vaccine available actually for children under the ages of, I think, under 12. Because Pfizer has now rolled out from 12 years and above, or I stand to be corrected, but we don't have any vaccine. So our this Sinovac vaccine is looking at children from the age of 6 months, I think, up to 18 years or under 18 years. And we have also participated in the Bill and Melinda Gates Medical Research Institute. So we are currently doing a TB vaccine epidemiology study. Now, this epidemiology study, once the data has been analyzed, is to look at the prevalence within the country of TB and how we can come up with a vaccine to prevent TB. So that's what we are working with the Gates MRI Institute. And we have also worked with Pfizer, or we are working with Pfizer, which is one of the sponsors as well, looking at a treatment medication for treating COVID-19. You'd know that currently there is no medication to treat COVID. It's mainly what we call the standard of care. So basically, this is who we are in a nutshell. And our vision is to be a preferred transformational partner in scientific research. And when we talk about being a preferred partner, we are talking about 3 things, actually 4. The first one I've already mentioned is that the fact that we are Black, that makes us a preferred partner. When we look at our policies, our triple BEE policy, it encourages participation of Black-owned companies. It encourages participation of Black investigators into clinical research. And that's why we are saying we would like to be a preferred transformational partner. The second part of it is the data that we are collecting. The processes that we are making, that we are following in terms of collecting our data, it gives the sponsors the assurance that the data that we are collecting is a credible data and it can be trusted by the public. Over and above that, we also look at, we talked about the data that we are collecting, but the quality in which we collect this data. Lastly, is the ethical part of it. But I also want to talk about the speed at which we are recruiting our participants. So in a clinical trial, what the sponsors or pharmaceutical companies are looking for is to get the drug to the market as soon as possible. So if they can work with a company that is able to help them to achieve that, that's why they would consider us as a preferred partner, because of the speed at which we recruit and the quality of our data. And then we also talk about a transformational partner. Being a transformational partner, it means that transformation, we know it as it's not an event, right? It's a long-term process, and SAPRA defines it nicely, and I'm sure my colleagues will share with us on that one. But when we talk about that capacity building, that we talk about being agile and flexible in what you are doing, so that the industry changes quite rapidly, and it needs us to be able to be adaptive, to be able to change with time and not be stagnant. You know that we are highly regulated. The regulation may change. As it changes, what does it do to us? How are we affected? And are we able to implement that? And then the last one is the partner part of it. When we talk about partners, we are saying that we want to work with companies that are not just going to come to our site, use the site and leave. But we want companies that would understand that we are in a developmental stage, and in that, when we partner with them, we want them to say, we want to come back and use your site again. So we don't just create a site, capacitate the site, and then we don't have any work. So we do have those facilities that we have. We want pharmaceutical companies to come and use them, but when they come and use them, we want them to partner with us. We want them to create work there, because you can have a center. If there's no work, then there's no use for having a research center. So that's what we are talking about when we talk about a transformational partner. And we have also specified the area that we want to be this preferred transformational partner within the scientific research. And how are we going to get there? So we have looked at different ways to say, we've got this vision that is so big, but we need to find ways in which we can achieve this vision. Firstly, we said we are going to accelerate. You know, when you put your feet on the pedal or in a car, when you accelerate, it means you are moving faster. So that's what we are trying to do. We are trying to accelerate scientific research by providing research infrastructure. Professor Makafula has mentioned that we are looking at setting up a research facility in the Free State or in Bloemfontein. That is part of the infrastructure that we are talking about. But the infrastructure is not complete if it does not have the human part of it. It's not complete if it does not have the equipment. It's not complete if it does not have the resources. So the infrastructure that we are trying to develop is to say, once we have identified a facility, how do we make sure that we get the right qualified people to be able to run this center? Then the next part is to create a platform for researchers and healthcare professionals to be involved in clinical trials. I bumped into clinical trials. I did not even know that there was a world like this that existed until I worked at NHLS, and there was a study that was being done. The lab now, they are coming, and we have to handle them differently than the normal labs that we were doing. And I was quite intrigued, actually, to say, now what are we doing? They mentioned, no, this is a study. Yeah, study, clinical trial is the same thing. So they said, no, we are doing a study. And I got more interested to find out, what is the study? How does a study be, who does studies and so on? So we want to be that platform. We want Cut-Crismo and CUT to partner to create that platform for researchers, those who are interested in research, for healthcare professionals. And being a healthcare professional, we're talking about your lab technicians, we're talking about your pharmacists, your nurses, your doctors, your physiotherapists, social workers. Actually, clinical trial has got a space for everyone to be part of it. But I will share more how that can happen. The next part is to conduct ethical clinical trials. So when we talk about ethics, we always refer to doing something right when no one is watching, something like that. So what we are saying is that we want to conduct clinical trials in an ethical manner. We want to make sure that all our trials are approved by the regulator, which is SAPRA. The studies that we are conducting have received ethical approval. The studies that we are conducting have received facility approval, and everyone that is involved have got what we call good clinical practice, which is compliance to the standard of conducting clinical trials. So these are the things that we're talking about when we talk about conducting ethical clinical trials. The next part is what we want to contribute towards the improvement of patients' quality of life. We know that in CUT we've got a unit which is quality of life and for the living. I am not sure the right word. Professor Makafula will kill me. So when we say we want to contribute to the quality of life, when you are doing clinical trials, when you participate in clinical trials, you are giving yourself an alternative. You are giving yourself another opportunity. If you've been diabetic for the rest of your life, and you've been taking this medication and diabetes is not going away, I mean, clinical trials are giving you an option to try again. It gives you the hope that there's something that is going to happen. And over and above that hope, remember, being part of a clinical trial, you are contributing to science. You are also contributing to make sure that there's medication in the country. So how do we teach our patients? And remember, me and you are going to be patients at one point if we are not patients already. So whatever the medication that we are taking or we will be taking, it goes through this clinical trial process. So we need to make sure that the people who are involved in that process are ethical and they understand what is expected of them, and that the public can have the confidence that the medication that we are putting in the market are actually scientifically effective and safe. We also want to embrace technology through innovation and training. As technology takes over our world, companies are digitalizing, but how do we innovate in that space? When we talk about the life cycle of a clinical trial, we are looking at from start to the end, from drug development or drug discovery up to your post-marketing. When we look at that process, we are saying, how can we innovate within this process? What kind of training do we need to have? Hence, we are partnering with institutions like CUT to say, can we develop a partnership to develop programs that can ensure that we train as many people as possible. We had a meeting this morning and we were talking about opportunities that are available within the laboratory space, for example, and here in the Free State. So there's a company that is actually struggling to find lab technicians. I could not understand that. If you say you're struggling to find lab technicians and we've got an institution that is producing lab technologists, what is the challenge? We need to look into that, and we will work with the department to see how can we create a channel that once one is qualified, they are able to be placed within this within research and these opportunities that are available. So that's what we are working on. Lastly, we want to contribute towards policy development. So when we talk about contributing towards policy development, we are saying with the research that we are doing, when do we get to publish this data? Now, what happens is that pharmaceutical companies are collecting data for the purpose of registration, not for academic purpose, not for any other purpose, or not to inform, but to make sure that their drug is approved, right? So we need to collect this data to prove that the drug is safe and effective, or to prove that the drug is more effective than the comparator. But what then happens is that this data is used to apply for the drug to be registered. We, on the other hand, are scientists, are researchers. We are interested in what happens, what happened actually in this process of collecting this data, what happened once we have, with the patients that were part of this clinical trial. That's why we want to partner with the university to say, all the studies that we have conducted, I've mentioned 20 studies, all those studies, we've got publication rights with the pharmaceutical companies. We have not published them. At what point do we sit down and look at this data and say, inform the public about what is happening? But we don't have maybe the capability, because we are a small company, we don't have even time to be able to look at this data and get it published. But I'm sure with a partnership like CUT, there are fundis who are really interested in this kind of things, and they like reading papers, putting proposals together. Perfect. We need to make sure that we give them that opportunity, give them the space to be able to write up something and get it published. Once it's published, when you go to the Department of Health or when you speak to policymakers, you don't speak to policymakers about what you think. You need to convince them by publishing. So the more publications we issue out, the better. So when there are references or there are citations, they come from these particular publications. That's how we want to inform a policy. And we talked about the kind of people that we want to work with. So our values are actually our DNA. So if we take your blood and test it, it must have professionalism. It means that the people that we work with, they are professional. They understand the sense of agency that is expected of them within the industry. We also talk about we need to be ethical, doing the right things when no one is watching. So Standard Bank gave us this award. No one was watching. We didn't even know that they were watching us. But the fact that we were recognized, that's what we are talking about, because you are doing things not for anyone, but for the advancement of the cause. And then we talk about accountability. We need to be accountable to one another. We need to take responsibility. Now that we have delegated something to you, you've been given that responsibility. It is your responsibility to account. You need to come back and say, this is how far I am. And this is the kind of values that we aspire to. Lastly, or second last, is your confidentiality and empathy. We need to maintain confidentiality. And over and above that, because we are working with human participants, these are not robots, they are not animals or lab rats, they are people. Now, when we are dealing with them, how do we become ethical in what we are doing? Or how do we become empathetic in what we are doing? Making sure that we put ourselves on the other person's shoes. We will go out to the community to recruit participants. When we go out to the community to recruit participants, how do you approach them? How do you speak to them? Some of them, they say, you want to make me a guinea pig? We must get them to understand that when we do clinical trials, we are doing them in an ethical manner, and they have gotten all these approvals. So we don't even call people guinea pigs. And we explain to them that being a volunteer or a trial participant, it means that you are contributing to the cause. You're contributing to making sure that there's medication for someone who's got a disease like yours. So we need to find a way, an empathetic way to address our recruitment. So this is our organogram, our structure. So we've got, I'm leading basically a team of 10 people who are managers looking after different departments, and I will share those departments with, and they've got the operational and support staff that they work with. The departments are regulatory and quality assurance. So when we talk about regulatory and quality assurance, we are looking at the submissions to SAPRA. We are looking at those approvals that we need to get from SAPRA. We're also looking at ethics as well, the ethics committees that we need to work with. But within regulatory, there is a lot that we need to look after as well, maintaining what we call the investigator side file. The sponsor would have their master file. We've got the investigator side file. How do we make sure that those two are always linked together? We also talk about data management and records management. You would know in clinical trials, majority of the work that we do is still paper or paper-based, as much as we are using an electronic system, but data is still collected manually. And when we talk about innovation and technology, we need to say, how do we now start to collect data electronically? How can we develop electronic medical records? So that when the doctor is seeing a patient, they can just include everything there in real time. The patient moves to go to the nurse puts the information there in real time until the patient is paid and they go home. But that's the process basically that we are trying to look at. But the data that we are collecting, is the data that we are collecting accurate? Is it complete? So that's basically what the data management team is looking after. Then we've got our clinical operations as well as support. So we look at the timelines, basically what we call service delivery. How do we deliver the service to the clients? The operations team is looking at those kind of timelines and milestones to make sure that we don't miss an opportunity. Participants who are on the clinical trial, they need to come for follow-up visits. They need to be on time or on schedule. If they are out of schedule, it means we are deviating from the protocol. That's a problem for us. So we need to then have a team that looks after that. Then we've got our community license and patient recruitment team. So they are your social workers. They are the guys who go to the community. They speak to the community. They tell them about the work that we are doing. They recruit them to be part of the clinical trials. But over and above that, it's the relationship that we need to build as a research center with the community. Because so there is what do they call CAP?
Community advisory.
A community advisory board. So these are bodies or structures that we need to set up within the community to make sure that whatever research that we are doing has got advocacy within the community, but we translate the research into practical within the community. And these are the people that we need to trust and develop to make sure that because you don't want resistance from the community. I'm sure when HIV started, there was a lot of issues when it comes to there were groups that believed that HIV or ARVs were not good for human consumption. There were the other group that believed that actually we need HIV medication. But it is the community, it is that community advocacy that pushed and made sure that now we've got ARVs and they are freely available to everyone. So we need to establish that. Over and above that, we've got our general administration that looks after finances and IT. And then we've got the human resource department. And then we've got what we call an on-site and home visits. What COVID has taught us is that we thought that clinical trials are only run at a particular site. So patients will need to come here, we look at them there. But COVID has shown us that actually you can conduct virtual or telemedicine. So the doctor on the other side and the patient on the other side, if we have given you a thermometer to look at your temperature, you just put it there, you wait for that sound, then you tell the doctor what is your temperature. So things are now becoming patient-centric as compared to going to the practice or to the site to go and conduct your visits. So These are some of the incorporations that we are looking at and say, can we have then this department that looks at what happens on site and what happens on at home of the participants, that the quality and it's still maintained. Lastly, it's the clinical investigative services. So we've got the investigator team that is looking after our protocols and after the safety of our participants. Dr. Fadan will share more about the role of the investigators. And in terms of what we do as a company, so we are a clinical trial site. We conduct clinical trials. So we have got the capabilities to set up a clinical research center according to the guidelines. We also conduct phase 2 to phase 4 clinical trials. And I'm not mentioning phase 1 because phase 1 is a more specialized kind of a phase. It needs certain resources. Here in Bloemfontein, you've got a phase 1 unit which under FAMOFS. So FAMOFS phase 1 is actually first time in human. So before the medication is actually given or taken to the next phase, it must then be trialed under phase 1. These are your healthy participant, someone who does not have the disease. And then phase 2, it will be or someone who now has got the disease. We want to look at now the dosing and the safety, obviously. So we need a capability to be able to set up a phase 1 unit. So that phase 1 unit can be able to do the first time in human, and then we can progress to the last phases. And your phase 4 is when the drug is already in the market, and now we are looking at safety as well, the profile of that particular drug, and what are the common side effects. We also look at medical writing, clinical study protocol and reporting. So what we do is we talked about publication, Professor Makafula. We say that we want to publish. For us to be able to publish, we need to have the skills to write. The paper that you guys don't read inside the medication, that is what we are doing. So at the end of the day, we will put that paper in the medication for you, and it will tell you what are the dose, it will tell you what are the common side effects, it will tell you how to take the medication, and for which population should that medication be taken to. So that's basically what we talk about in medical writing. And then we also recruit volunteers or participants of clinical trials. We also do what we call regulatory submission, regulatory as well as ethics. So there are different types. If you are not doing an interventional study, you don't need SAPRA. It's more an observational study or whatever the method you are using. But if you are using an interventional study that has got a product, you will then need to get your SAPRA or regulator approval. So basically that's the services that we'll provide. And then the last part is what we call the clinical research capacity building programs. This is my passion. This is where I really want to focus my energy in. And that's why the partnership with CUT is very important to me, because when we talk about capacity building, there's so much that we can do within the clinical research space. There's so much that we are actually not doing within the clinical research space, and we'll talk more about that. How are we developing this capacity? I just wanted to share maybe with you the kind of studies that we are currently involved in. We've got a study called Evergreen. So Evergreen is a RSV study. Don't ask me what is RSV. It's a respiratory sensational virus. It's by Johnson & Johnson. So we also have got, and this Evergreen is looking at the elderly. So from the ages of 65 and above. This is one of the infectious diseases. And then we've got what we call Protect AP. Most of our studies have got names. So when we say Evergreen, it's a name of the study, but when you look at the protocol, it will have the entire title, phase 3 randomized double-blind placebo-controlled study to evaluate on whatever type of patients. So, and then Protect is looking at patients with, so it's a contact study. So they are looking for patients who tested positive, but we want to follow up their family members or their the people who live in the household. So we are not targeting the one who is positive, but the family members, to see if we can be able to protect them from acquisition. The next part is a pediatric COVID-19 study. We are currently busy with it. At the moment, we are actually testing a vaccine study under Sinovac to see if it can be able to prevent COVID-19 hospitalization, death, and so on for the children under 18 years. And then we've got Victorian Study. Victorian is looking at patients with dyslipidemia. So it's a cardiovascular study looking at patients who have had stroke or heart attack but a CVA patient and with dyslipidemia, which is cholesterol issues. And then we've got what we call PRO, COVID-19. So actually I swapped them around. The pediatric one is a treatment one. So this is treating children who have tested positive for COVID. So we give them this treatment and follow them up. Here we are looking at the pharmacokinetics of the drug. It's quite an intense study and it's quite difficult to recruit as well. And then Ensemble is the Johnson & Johnson study. I mentioned that it was a COVID vaccine study that we did in the beginning of 2020 when COVID was just was hectic. And then we've got Select. It's also a cardiovascular study looking at patients who have had who are non-diabetic but who have had a CVA. And then the last one, or not last one, and then we've got Be Together. Be Together is looking at chronic hepatitis patients, and we wanted to find out if this medication from GSK will be able to assist them in their. Then the next one in their disease, the next one is Ministone. Ministone is looking at influenza positive, influenza A or B. So we are looking for children basically under the age of 1 year. This is a phase 4 study. We are looking at a medication called baloxavir. It's already registered. So it's just to look at it for the children population. So looking at patients with influenza and what they call tympanic temperature. And then we have just concluded recruitment on the Gates MRI study. This is a TB epidemiology study. Within this study, we are actually looking at the prevalence of TB in the community. That data will then be used to select us as a site for a TB vaccine study. So the Gates Foundation are currently working, not foundation, the Gates MRI, they are working on a TB vaccine study, and they will be coming to our site sometime in July as well to look at our facility and see if we can be able to participate in this. And we have just concluded a TT study. This is a hypervolumia study looking at patients who have lost blood and who present at casualty basically, and that, this medication was helping to push up some blood pressure. Don't ask me how, and the doctors are here to explain. And then we've got the RayMed study, which is looking at, it's a genetic study, this one. So the organization wants to develop a biobank, right? So we are going to be looking at different diseases and just to follow these patients up for a period of 5 years. In this period, we'll just be calibrating their medication and just to follow them up and see the disease progression and so on. And then the last one, I've mentioned it, it's the, this was the Pfizer one, is a candidemia study, looking at patients with candidemia or candidiasis. Candidiasis. Yes. Okay, so basically that's what I wanted to share with you, and here it's mainly what SAPRA is defining as capacity building. So in 2018, they issued some guidelines to say we need to develop capacity building in the country, and for us to develop capacity building, there are areas that we need to focus on. If we are going to be conducting multinational clinical studies, or if you are going to be conducting multi-site studies in the country, 25% of the sites that are participating, they must be 100% Black owned. They must be academic sites. They must be public health sites. So these are the 3 criteria that the Department of, that SAPRA has listed in their guidelines to say, moving forward, we will not be approving studies that do not consider this as part of capacity building. So they say it's a long-term process which includes all stakeholders, including academics. So we know that in this process, we need to make sure that we work with academics, hence the partnership with CUT, to say how can we take advantage of the policy and also create capacity within the country. When South Africa has got capacity, when we've got more research site, Dr. Kosi will talk more about the perspective within the clinical research. But when we participate in clinical trials as a country, we are competing with the world, because the protocol developers or the pharmaceutical companies, they need to decide where am I going to conduct my study? But if South Africa has got that competitive advantage, which is the research centers, which is the scientists, which is the facility and all those things, then we bring more work into the country. And then more, then we continue working, Dr. Makafula. The other part is it focuses on the need to use our resource capability, what I've just mentioned, so that we develop the country. And the goal of capacity building is to tackle challenges related to policy, methods of development, and what is limiting for us. So when we talk about publication in our mission, when we talk about informing policy, this is what we are talking about, that the work that we are doing, we must share it so that we are able to inform policy and develop the methods of management of patients. Lastly, in our context, capacity building includes addressing historically disadvantaged groups or marginalized from the mainstream research activities. They continue with us as Cut-Crismo. Our mission is to increase our footprint in clinical research. We need to develop capacity building collaborations. And we also need to increase the participation of public health institutions. And it's not only public health institutions. I mean, if we look at in South Africa, 80% of the people who are using public health institutions are Black people, and the majority of them are not even participating in clinical trials. Now, when this medication is available, when we look at the sample size, it doesn't match. Now, how do we get them to be part of these activities? We also need to create a platform for science graduates to develop industry-related experience through creating these research opportunities. So we are saying through our collaboration and partnership with CUT, we want to inform and we want to create this platform so that when you graduate at the end of the day, you don't bump into clinical research. You know that there is an industry called clinical research that you can go into. I mean, you don't have to complete your national diploma in biotechnology and go to work in the lab. There are other areas that you can also work in. You can be a project manager, you can be a study coordinator, you can be, actually there's a lot, a clinical research associate, there's a lot that you can be with that particular qualification. How do we introduce that and make sure that you also take advantage of that? In terms of the evidence, to date, since 2017, we have trained on exposed 18 BSc graduates. So these are the graduates that we are hosting as interns, right? So they would come in, apply for an internship, we appoint them and we pay them the stipend. So for the period of 12 months, they are able to learn clinical research from start-up, conduct up to closeout. So they go into the entire, so within a site, you've got a pharmacy, you've got the clinic where the data has been collected, you've got recruitment, you've got the lab, so there's so much that is involved, and we want to expose them in every area of that so that when they finish the program, they are able to go and work for the industry. And out of this 18, most of them are working for the pharmaceutical companies. Now we've got advocates basically within the industry. We currently have got 31 full-time employees. This is, we have seen this increase, especially when COVID started. Then we had to get a lot of recruits to be able to join the company. So we are only 6 years old as a company, and to have 31 people, Prof. Nel, it's really an achievement for us. We also participate in multinational clinical trials. I've mentioned those studies that we are working on. These are not South African studies, they are global studies. So South Africa is participating as a country. So for us to be part of that, I think it's one of those capacity building opportunities that we are talking about. The partnership with CUT, this is one of the biggest milestones as well, that we say, we are in the right direction in terms of creating capacity building. And then lastly, it's the number of clinical trials that we have conducted. And I say the data is sitting there. It needs someone who is interested to just come and look at it and help us to get it published. Thank you very much. And that is all I had for you for today.
Wow.
Yeah. Wow.
Wow. I'm breathless. But thank you, Ntate Qindi, and welcome, Prof. Nel. And welcome to other colleagues who has joined in while the presentations were on. It takes us to our next agenda item, which or program item, where we will be requesting participants to ask questions, and the presenters, both Prof. Makafola and Ntate Qindi, to respond to questions. This is how we are going to address questions. The participants on Cloud, you are also welcome to send in your questions through the chat board. We will read them and our presenters will respond to those questions. Will that be in order? But before we do that, let's give Ntate Qindi and Ntate Makafola a round of applause. Questions?
Yeah, Chair, I'm going to sit, I believe, for the sound of online. I'm not involved in the Department of, what's your school?
Faculty of Health,
I'm
Health
from
and
the
Environmental
I'm
Science.
from the Faculty of Management, and I'm in the Department of Accounting and Auditing. But I'm very interested in the financial part of clinical trials. And I'm just going to mention is my wife. She's involved with clinical trials. She's part of a clinical trial site in Bloemfontein, Iatros. So I do know quite a lot about. And I already assisted them a lot with firstly, I started off with Excel templates on visiting schedules and so on. So, but when I moved on, it actually prompted me to see, it challenges me to see the accounting side of this thing and the financial side. And in the end, I did a presentation at the SACRA conference, the National SACRA conference, I think in 2018, on the financial side and how to use accounting software for the proper. So that's why I'm here. I'm here to say I'm available. I want to offer my knowledge on the financial side of clinical trials, because there are different challenges. The patient is not the debtor. The sponsor is the debtor. The patient is actually at some stage a creditor, because we owe them the inconvenience fee. So there's a lot of very technical financial things about, and that's actually my interest. I'm here to offer, if you want my participation. I just want to know, Crismo at this stage is a clinical, it's a site. So you got a facility in Gauteng somewhere, and your aim is actually to if I'm correct, your aim is to try to establish a satellite site at CUT, or am I wrong?
Okay, so the site management, like I mentioned, SMO is a model, right? It means we are managing multiple sites. So we are a site management organization. We have got a site based in Germiston, where we are conducting majority of the vaccine studies. We've got a site based in Krugersdorp in Leratong Hospital, where we are conducting hospitalized studies. And we want to extend our services to the Free State, where we set up another research site in partnership with CUT. So then we'll be able to have 3 sites that we are managing.
From my side, who's doing your finances? Do you have a financial officer doing it currently from the central office?
Yes. So from the central office, we've got part of the management team. We've got the finance person who is looking at all the finances for the different clinical studies.
That's fine. When I just want to position myself, So Sorry, I've made some notes here. Your PIs, are they full-time employed or do you sometimes contract PIs?
So there are those who are full-time employed, and we've got also
Because I saw a few names there, 4 or 5. So some of them are full-time.
some of them are contract.
Contracted.
So yeah. My apologies and thank you for that. Yeah, so just to clarify that, I remember you actually at SACRA and the SAGE system that you presented there, and how it can be assisted, how it can assist clinical trial site. And what I can confirm is that we've tried to write a proposal on the site experience when it comes to payment from the sponsors, and that was just to try to look at what are the challenges that the sites are having when it comes to executing their contract. And most of the time was the delayed payment. Now, when payment is delayed, now you've got the participants that you must also reimburse. How do you manage that process? But you are actually correct that it's a complex financial model, and I mean, I'm happy that you are available to help us and bundle it. Part of the work that we are coming here to do is to create those kind of opportunities. So when you say you are positioning yourself, that's actually the correct way, because we want people to position themselves. We want people to say they are available to do this kind of job, particularly the research investigators as well, to say we want to come to the Free State, who will be interested to work with us.
Okay, subject recruit. You say you do phase 2 to 4. So phase 2, does that include sleepover patients, or is it only?
No, so it does not include sleepover patients, unless if it's a phase 2 that is doing pharmacokinetic, where patients might stay on site for more than close to 10 hours.
So you do have those facilities?
No, not to sleep over, but we can entertain them for the 10 hours. That's the right way.
I think you've answered. I just want to mention something. Prof said something about the GCP course. It will be a year course. And I know that the GCP course, sometimes they offer GCP over a 2-day period or an online course. So I just want to mention that, because the GP, I don't know how you're going to structure it, but just about the GCP course. Okay, but thank you, Doctor.
Thank you.
And I'm here if you want me.
And I'm not a doctor, so.
Yeah. Yes. Thanks. I think the idea behind trying to offer a much more intense GCP course is so that we try to get it valid for quite a number of years, if possible, with the registering bodies like South African
Can I make a
Profession Council.
suggestion there that when you come to GCP, in that course, there need to be, from my side, some financial training as well. Because my experience is that, and I've in my preparation for the SACRA presentation and whatever, currently the financial side of clinical trials is, with those, I've mingled with quite a few sites. That is a challenge, and I'm talking about huge sites that they're struggling with the financial management of clinical trials.
Yes, indeed. It's actually one of the reasons why it is a much more intensive course, to make sure that we have like financial management as part of it, project management as part of it, unlike having a 2-day online kind of course. Yes. Thank you.
Thank you, colleagues. Any other question? Ms. Dlamini?
Thank you. Just for interest's sake, I would like to know whether your organization, like, which type of clinical trials you do, like, you take all forms of drugs and also all classifications of drugs or other medications, or you are selective on the types of medications that you are willing to study?
Okay, so thanks for that question. I think what we do is we do a feasibility. So every time there's a new drug, whether it's a treatment or it's a vaccine, we would conduct what we call a feasibility study. The feasibility study is to help us to know whether we do have those type of patients, whether it's a treatment, or will the patients be willing to be vaccinated. So the feasibility study will tell us that we are actually doing, but you also want to look at the area that you are in. What is prevalence in the Free State, for example? If we were to bring a study in Bloemfontein, what kind of indication will that be? Hypertension, diabetes, or vaccines? So we always conduct those kind of feasibilities.
Can I make a remark? This is from my side, personal side. I think the studies must serve the community
Yes.
that they are in. I mean that so that the community knows that this is not we are guinea pigs. This is actually a service that we can get for free.
Yes.
And it's going to actually improve our health. And there must be that trust. There must be, this is a whole community engagement.
Yeah. No, thanks for that comment. That's correct. Yeah.
Professor, then.
Thank you very, very much, Major, for the interesting presentation. Apologies, Prof. Makafula, that I missed yours. So in line with what Mr. Herter just said, and you also mentioned that in your presentation, is that there is this conception that, those who participate in a clinical trial are guinea pigs and something bad may happen to them. And also the involvement of the diverse population is actually very, very important. So are there some, I want to say, awareness campaigns that you are launching, because to make people realize how important it is for them to be available because of the importance of their contribution. I know when there was lots of talk about the vaccine for COVID and so on and so on, they always look at which population were actually used to get the answers from. And then in many cases, it says that, as Africans, we may be unique in certain ways in our DNA or whatever the case may be. And as much as we want to say we are all human beings, there may be some differences in how we may react to something compared to what a study in Europe or whatever the case may be. I would just like to hear your views on this. Thank you.
Thank you so much for that question, Prof.
Ms. Wu, is it for Untitled?
Okay, so can I also take that question as well, and then I'll answer both of them?
Yes.
Okay. So in the past 6 years since you were at the say when it comes to medication comparison, have you done most of medication to medication or medication to placebo?
Okay. So thank you so much for that question. And Prof. Nel, so clinical trials are now looking at that issue that you are mentioning, that there's lack of diversity in the data that we are collecting. If you are conducting a study, for example, in Europe, you are likely going to find Caucasians. And your sample size would be about 80% would be your Caucasians, right? So now, how do you diversify your data? And Africa, it's actually where it is happening. But I can talk about South Africa. So Dr. Kosi will talk more about that. But South Africa is unique. We are the only country in the world that has got Black people, that has got white people, that has got Chinese, that has got Indians, that has got all the races. So other countries, you only find two races. It's either black or white. That's it. But with us, we have got colors. I forgot. So our pool is bigger. That's why we need to make sure that South Africa becomes the clinical trial hub, where we can. But now the comment that you make about education becomes very important. How do we make sure that when we say South Africa is a clinical trial hub, how do we then communicate it to the participants, communicate it to the community, and those educational activities are really important. Unfortunately, we do not have any campaign at the moment. And it's something that I think it's very important, and we need to make sure that part of the work that we are doing is to educate our community about the work that we are doing, also about why it's important to be part of clinical trials. I hope that gives you
Can I
thank you.
just make one last remark, because now I'm standing between you and lunch. But I think, and I'm glad you said that. I saw somewhere the Department of Health. I think the Department of Health can play a huge role in that, because, like you said, 80% of the people go to public health, and so if Department of Health can assist with that knowledge sharing and participation, so that the subjects know that this is actually a service and not a guinea pig's game. It's a service being offered, and it's been endorsed by the Department of Health. So I think maybe that's an idea that the Department of Health, if they can buy into this and assist.
Definitely, I agree with you. Thank you thank you so much for that. So the Department of Health, we need to inform them. We need to show them that there's a need. At the moment, yes, it's there. They know why they've created SAPRA, they've created the NHREC, and so on. So they are aware of it. But how do we then advocate for it so that then it can be part of the community knowledge? So I do agree. And in terms of the studies that we are doing, so if you are going to do a new medication that is not already available, so you can't compare it to anything. That's why placebo control comes in. So you want to have your active and you want to have your control. And I mean, the researchers here, they would know about those methods, qualitative and so on. So if there is already medication for diabetes, for example, and you come up with your product, then you need to say, my product is superior to this one based on the research that I'm doing. So you can't compare it to placebo because there's already something available. So that's basically how the placebo control will come in versus the active ingredient. Okay, thank you.
Thank you, Ndate Kindi, and thank you, Prof. Makafula. Just to give our participant an assurance, the Department of Health in the Free State Province is aware of this workshop, it's aware of this partnership, and they were supposed to be part of this, but due to another youth related event. This is the Youth Month. They are unfortunately not part of this, but I would like to reassure Cut-Crismo and colleagues who are not from the Faculty of Health and Environmental Sciences that indeed the Department of Health in the Free State is on board. And we don't have the agreements as yet, but it's still work in progress. But I would like to reassure everyone that this. My comment from where I'm sitting with regards to the presentation, it is challenging us as communities out there. Before we can become researchers, can become, employees of Central University of Technology or consultants at Cut-Crismo, we are community members. So we are being challenged today to go back and advocate for our full participation. And Dr. Kindi made a critical point to say, the majority of our health services institutions are serving the Africans. And in these studies, the number of participants of African descent is quite less. So we are being challenged. I, for one, as one of those people who are using the services of the public sector, I think it's upon myself to go back and teach and advocate for our full participation in these trials. Until we tell them that indeed this is what is good for us, then nobody will take it upon. So I'm also challenging participants here on the in the room as well as on cloud to go back to our own communities and say we really need to come up and be part of this service that is being provided here, and we are not the guinea pigs like we are known to be. We are just people who want what is best for our own people, our own South Africans, and for our own good, healthy living as South Africans. So this take us to the moment we've all been waiting for. We will break for lunch and we will come back at 2 and we will continue with the 2 presentations from Cut-Crismo and a feedback from our research office as well as from the acting dean in the Faculty of Health and Environmental Science. Thank you very much. A round of applause to everyone here.
Okay, lunch.
Ya utlwa.
Oh, sorry. Uh,
Okay, meeting. But before,
Okay. Thank you, ladies and gentlemen. Welcome back. I hope we all managed to stretch our legs and have a little breather. Thanks to Ndate Measure with such an insightful presentation. I'm still trying to comprehend and identify the role that I will be playing going back to my community.
positioning.
So he really made it very easy for us and more interesting for us. If you are not touched by what he has presented, I think, yeah, we need to take you to some. Thank you. We have started. We will go back, we will resume with our program, and we have two presenters who will be taking us through our program. Two presenters from Cut-Crismo. The first presenter will be Dr. Cozy. He's a clinical manager and research investigator at Cut-Crismo, and he's going to make a presentation on overview of clinical research perspective in the South African industry and regulation. I hope I pronounced it correctly. Ntate Koza, I would like us to come join us here on the podium and continue with your presentation. Let's welcome Ntate Kozi.
Good afternoon, everyone. Thank you for having me. Is this clear? Everyone can hear me? Great. Let me just try and battle with technology quickly. This one. There we go. Okay, that wasn't too hard. And how do I... Oh, there we go. Okay. Good afternoon, colleagues. Again, thank you for having me. My name is Dr. Sipho Kosi, and I'll be giving you a brief presentation about clinical research, the overview of it in South Africa and Africa as a whole, just to give you a better idea of what it is we do and why it is so important. So, over the last couple of years, research trials have grown in numbers all over the world. However, unfortunately, South Africa and Africa as a whole actually has lagged far behind. And this presentation will be going through why we're behind, how we're behind, and possibly how we could catch up. Now, we were talking about finances earlier. So I figured we'd start with probably the least important part of what we do, but it is a huge part of it nonetheless. So internationally, the clinical trial industry generates over $47 billion. And this is expected to grow at almost 6% annually by 2030. Now, if you compare this to the automotive industry, that growth rate is only expected to be about 2%. So this gives you an idea of how huge the industry is and how fast it's growing. And pharmaceutical companies are ramping up, investments in Africa. And we as South Africa and Africa as a whole could play a huge part in this growth. And I think it's incumbent on us to be a part of this. So in general, studies have shown that scientific research as a whole is a strong driver of economic growth. Clinical research not only provides financial opportunities, but also improves health and lives of citizens. This means that research, what we do, has a twofold effect on our society. Africa is facing an increase in non-communicable diseases. So previously, we've been viewed, Africa as a whole has been viewed as mostly communicable diseases, so your infectious diseases, your HIV, AIDS, your malarias, your Ebolas, TBs. So our research has focused around these diseases. However, due to globalization and modernization of our society, Africa is seeing a huge increase in non-communicable diseases. So your diabetes, your hypertensions, hypercholesterol, cancer. So this is quite similar to the trend that we see in Western countries, which is putting us in position with Western countries to do this clinical research, which means that more pharmaceutical companies will be tagging along in Africa. So just a random fact that there are estimates that it'll be about $38 billion spent on oncology research internationally. Now, where does Africa fit in all of this? Over 1.3 billion people live on the continent of Africa. This makes up about 17% of the world's population and some of the poorest on Earth. And it also has the highest disease burden of any continent in the world. It's estimated that we hold about 25% of the world's disease burden. Now, with all of the above facts, Africa makes up less than 2% of the world's clinical trials. Now, when we add that to the money, it's obvious that how far we're behind and how much we could actually contribute considering the amount of people that we have on the continent and the disease burden that we have. So this is just a brief overview of the clinical trials internationally. We can see that we're lagging far behind the rest of the world. And in Africa, I suppose, pioneers of clinical research are South Africa and your Egypt. Now, why is it important? Why can't we just accept whatever clinical trials happen in Europe or America? Now, we alluded to this with Prof earlier on. Africa has one of the oldest and largest genomes in the world. This means that medicines that work on Americans, Europeans, Asians, where most research is done, this may not work as well on Africans or actually have some unexpected consequences, which I'll delve into a little bit later. So with the huge disease burden in Africa, African researchers need to be at the forefront of drug development and not just tagging along the coattails of the Americans and Europeans. So looking at the strides that we've made in HIV and TB treatment, it shows that African researchers are actually capable of implementing quality research. So COVID-19 showed that African researchers are able to contribute to clinical knowledge. So what are our challenges and why are we so behind? Well, some of the theories, it's lack of resources and infrastructure, like Major mentioned earlier on, somewhat of lack of expertise, concerns about data quality, which is why we're so focused on data quality at Crismo, and post-trial access to medication. So I believe this was mentioned earlier on as well. Are people just being treated as guinea pigs and then they're running away with their drugs and using them in Europe? It's important that we make sure that the trials that we do are for our people as well. And there's also a lack of understanding of clinical trials by our participants. I mean, as a clinician, I've had to field all kinds of questions, especially with this, with the COVID vaccine. I mean, there are so many theories that I won't even begin to get into now, but it's up to us to educate the community and help us improve this understanding of clinical trials. So just to wrap it up, I figured I would share just a small case study, a short case study, which kind of highlights the importance of research in the African context. So enalapril, which is an ACE inhibitor, is a widely used antihypertensive. Clinical trials in the United States have showed that it was effective and safe with minimal side effects. So with an increasing burden of hypertension, the South African government rolled out antihypertensive medications at large, including enalapril. This did help decrease complications and deaths that were caused by hypertension. However, in 2002, a patient in Grooterskeer died after failed intubation following what's called angioedema after receiving enalapril. Now, while angioedema is a known complication of enalapril, it rarely ever caused any deaths, at least according to their studies. Now, just to give you an idea of what angioedema is, it's swelling of the soft tissue around the mouth, the tongue. This causes a compromise in the airway, inability to breathe, and it's a scary sight to see, really. Now, back to the case. Studies previously that were done in America showed that angioedema was much more prevalent in African Americans than it was in Caucasian Americans. Now, if we sit back and consider that the Black population is a significant population in South Africa, it stands to reason that the incidence of this complication would probably be much higher in South Africa. Although not many deaths have occurred since, it highlights the need for African research. I mean, had we rolled out this enalapril trial in South Africa and done thorough studies on it, we could have possibly noted the complication earlier, not rolled it out, and studied the consequences further. So just a couple of takeaways. African research is huge and it is on the rise. It's critical not only to the economy, but also the health of the continent. So it's important to realize that health equals wealth. So we don't only deal with clinical trials and clinical medicine here. Our work goes far beyond just the clinical field. A healthy nation is a wealthy nation. And I'll leave it at that. Thank you very much. And Sister Puleng will just give us an overview of the regulations in the industry.
Good afternoon, colleagues. My name is Puleng Dlamini. I'm a registered nurse. I'm just going to give you an overview about regulation. Regulation is one aspect that is so important in whatever situation that you're in. You have to adhere to regulation for one to practice. As professionals, we have our regulating body. As a nurse, I'm affiliated to South African Nursing Council. The doctors are affiliated to the medical HPCSA, and other professionals like social workers or lawyers, they've got their association. So I'm just going to give you a brief overview about clinical trials and the regulations, because before any clinical trial is conducted, there has to be some submissions to the regulatory bodies, which is, in this case, the ethics committee, different ethics committee. We've got the different ethics committee, you'll see on the slides, and over and above the SAPRA, if any investigation involves the investigator product. Okay, the drug development cycle. This is very important because we're looking at this investigator product as to where does it start before it's ingested or before licensure. We're looking at the phases that actually takes about 13 to 15 years. It starts at a very preclinical phase, as you can see, the drug discovery, and the compounds are from 5,000 to 10,000. And they are further sifted to 250 during the preclinical phase. By the time they go to the clinical trial, look at phase 1, like 5 components. By the time they go to phase 2 and phase 3, before licensure, when it goes to be submitted FDA review, which is the Food and Drug Administration in the United States. Here in South Africa, we're talking about SAPRA, South African Health and Product Regulatory Body. By the time they come for approval, we've spent about 15 years, 13 to 15 years. So you can actually imagine the time frame before we actually maybe look at the drug like enalapril from the previous speaker. For one drug, it takes 15 years. The multiple drugs that we actually have every day that there's a new drug on the market, behind the scenes, this is exactly the life cycle. South African regulatory framework. We've got the regulatory laws of South Africa and the industry guidelines of the conduct of clinical trials. I've spoken about SAPRA. If there is any investigator product that is drug related, we have to apply to SAPRA. SAPRA is regulated by the Department of Health. And then we've got Ethics Committee. Ethics Committee is a national research ethics committee. And together with the Institutional Review Board, this Ethics Committee is actually looking at the adherence by professionals to conduct credible clinical trials. And it actually looks again at the risk-benefit issue of human participants. Other research platforms, we've got National Health Research Database. Dr. Kosi has actually shown us the whole, the world as to where are we in Africa about this National Research Database. And then we've got obviously the Provincial Health Committee and the District Committee and our hospitals. So these are other research platforms where research of human participants are held. Then we are governed by guidelines. Guidelines, we've got International Harmonization Conference of Good Clinical Practice. Everyone who works in the clinical, as in any aspect of clinical trials, being it a doctor, a nurse, a data capturer, a recruiter, has to go through this good clinical practice because it gives you a guide as to how do you attend or handle human participants. It's more of adherence to human rights issues. And then guidelines on good clinical practice in the conduct of clinical trials with human participants in South Africa. Declaration of Helsinki. This is one declaration that was promulgated in 1964. It's really looking at the ethical conduct of clinical trials, the beneficence, the risk-benefit issue, and it's these guidelines that makes a clinical trial professionals to adhere and be sort of very different from those professionals that are in the Department of Health rendering curative services. We really attend to human participants as humane and ethical as possible. We explain everything, informed consent form before we actually consent the participant. And if participant is not comfortable actually saying, I just want to go home with this form and go and discuss with significant other, the participant is allowed to do that. And we're looking at human participants, not people who are ill. We don't call them patients, we call them participants. And then the World Health Organization and other approved guidelines. We are really, if you are from a curative angle coming to clinical trials, it's a little bit tedious because there are a whole lot of submissions that are done. You cannot work in a clinical trial if you are not submitted with ethics and approved as a doctor. If you are not submitted to SAPRA and approved, any other professional has to be admitted to ethics and acknowledged. But the doctors have to be approved because these are the people who are assigned to look after human participants. They are the leaders in clinical trials. When a clinical trial is given to a site, the principal investigator is the one who has to sign that declaration that I am going to run this clinical trial looking after human participant holistically. Thank you.
I'm going to be consultative now. Do we proceed to the next presenter or we ask questions or do we do how do we handle it? Should I call upon the second presenter? We deal with the presentation and then we go back to question and answer session. Is that amenable? Thank you. I would like to call upon Dr. 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 That name. But thank you very much. Let's give our two presenters a round of applause and welcome Dr. That's his name.
Thank you very much for the introduction. Can you hear me? And thank you to Sister Pauline for softening. She just pointed towards the PI, Principal Investigator. So my presentation will be as projected, the role and responsibilities of the Principal Investigator, but not just limited to the Principal Investigator, to the investigators. Who can be an investigator? Before we talk about who can be, I'll just delve a little into the investigator. And the investigator has roles to play. Mainly, the PI will take overall control or oversight for the study. That is the role of the PI. And excuse me, looking at the oversight, there are other responsibilities assigned to that. However, before you can talk about being a PI, you need to have been an investigator, spend some time as an investigator, maybe seen 2-3 projects to completion to gain the experience to be able to play that overall side. So there's a pool of investigators, and there will be one who will be the PI. So the clinical trials are conducted by an investigator who has entered into an agreement with the sponsor to conduct a trial. I'll be moving between investigator and PI. So the PI will sign, as I was mentioned earlier, to commit to conducting the study according to the protocol, adherence to the protocol, adherence to ethical guidelines, and other issues associated with the study. And the PI will also provide leadership for the team, and that team could be as large as possible. And that team will have a nurse, pharmacist, study coordinator, we'll have data capturers, we have recruiters, social worker, depending on the nature of that study. The person is responsible for the conduct of the clinical trial, I think I've said that. And in the case where we have multiple studies, multiple sites for the same study, each site will have a principal investigator and a team of investigators. On the studies we've done in Cut-Crismo, there was one that had 2 principal investigators on 2 sites. And I'll also be talking from my experience. I was the principal investigator at one site, while my colleague, Dr. Mamba, was the principal investigator at another site, the 10th study. Because the sites are different, and what happens at that site, there must be somebody to be accountable for. So there will be multiple sites in the same country or across many countries or provinces. Each one will have a PI. So who can be a PI? And that's where I will start there, and also the categories. The PI must be a South African-based clinician and must have actively participated in at least 2 clinical trials as a sub-investigator. In time past, you have cases where the PIs are based in the Western countries who are providing the money, and they will fly into South Africa, gather their data. They won't call people living in South Africa guinea pigs, but they just come in there, do their thing, take the data, and get the drug approved, and also get publications if needed. But if we take the study, the case study that Dr. Kosi mentioned in April, if there was a South Africa-based PI, there would be a different outlook to the conduct of the study, and understanding of the study, because the South African-based PI lives in the country. I have been a PI on the study, and I want to point to you that it's South Africa-based, not South Africa citizen, because there's a difference. If I've not told you where I come from my accent, you can know I'm not South African. And from that name, you may also be able to pick. So that's part of the ethical issues. Nobody is discriminated against. What you just need to do is to be able to provide ethical conduct of the study. And it's very important for people based in that country, in this case, South Africa, to lead the study, so that how it affects the community, the country at large, will be better understood. The local PI has sole or joint responsibility for conduct of the trial and delegation of trial responsibilities. I mentioned some group of people that might be on the team, and each of those members must be delegated on that study. And by delegating, I mean assigning roles to each person. You can't start the study until that delegation has been done. The sponsors have got all the approvals. You've got approval from SAPRA, from the ethics, but at the onset, people must be delegated to their roles and be taught reminded, because they know what they are supposed to do, or be reminded of what they are supposed to do during the study, right from the investigator, the sub-investigators, to the other members. So the PI takes charge of that. Also here, a sub-I must be a South Africa-based member of the clinical team, designated and supervised by the PI. Earlier on, I said the PI takes oversight, and that involves supervision, guidance, and so on. There are cases in which we have co-PI. And in one of the studies, the Assemble study, at a point we realized that it would have been good for us to have two PI at the same site. So what I'm saying is that you might have sites, just one site of a study, and have two PIs, two or more PIs, with each PI taking charge of different sections of the study, the trial. And with the case of a co-PI, there might be one that is responsible for the clinical aspect of the study, while the other PI might be more of the pharmacy laboratory component of the study. But these are just to show you some of the categories. So when we are talking categories of investigators, we have the sub-I, we have the PI, could be more than one. And there are criteria to be met. So the PI, the main PI, if I can put it that way, usually is a medical practitioner. I don't know of any study that doesn't have a medical practitioner, or a dental practitioner, because there are also products that are mainly dental. So should be either of that, licensed to practice the profession in South Africa, and has attended the necessary training. All of us must go through the GCP and has a good understanding of the GCP, must be in good standing to practice, because if you don't pay your annual subscription, you're chopped out. That's the least. Another criteria to be met. The co-PI must also might be a clinician and qualified to also provide the same kind of oversight. Now, this is the GCP and good clinical practice. There's also the South African version of it, and this, I'll just talk through it. There's the international one, and there's the South African. So if you are going to be an investigator, you need to go through the both, because the South African GCP is tailored according to suit South Africa. It's just some modifications compared to the international GCP. So the qualifications and agreements, I told you about the qualifications. The agreements, the investigator, the PI will have an agreement with the sponsor, and also with the site, especially if the investigator is a part-time. There are written agreements. I can't remember your name, Mr. Ekler, was talking about finances and all that. The investigator needs to also know about the budget, the finances. Not responsible for day-to-day spending and paying and all that, but you need to know what the budget looks like so that you don't write up multiple visits. Meanwhile, the sponsor has approved 2 visits. Who's going to pay for the deficit? Those are some little things. But the budget and all those agreements with the sponsor, agreements with the site, and at every point, the investigator knows that your name is the one at stake. If anything goes wrong along the line, the site will be picked, mentioned, but the investigator will also be mentioned. And you could face, it's possible to face hearings if it was not properly conducted. There must be adequate resources and upfront, right from the feasibility period where the identified PI or investigator sits and looks at the feasibilities. With the resources we have here, are we able to take on this study? And if yes, if we are able to take on it, we don't have enough resources, we make requests about the resources. And when talking about the resources, human resources, human capital, the people that form the team, and the equipment needed, all those will fall under the resources. And the investigator is responsible for identifying the resources required and ensuring that they are available so that along the line we don't run into a hitch and start running up and down for additional. Medical care of trial participants, not just the medical care, but the safety of the study participants. That is paramount. Safety of the participants. Ensure that the patients are well taken care of. And in the event of adverse events, the PI kicks in to ensure that it's mitigated against and adequate care is provided at the relevant facilities. The investigator also has a role of communication with multiple agencies, the regulatory bodies, SAPRA, the ethics committee. Maybe there are some adjustments, and you keep hearing about version 1, version 2 of the protocol. Now they need to come for reconsenting, which I'll mention later, talk about later. So there's communication with those regulatory bodies and also the sponsors. The investigator communicates with them. In the event of adverse events, the investigator also communicates. Compliance with the protocol. The protocol for the period of the study is the Bible of that study. Everything must just align. The investigator must have a good understanding of that protocol because along the line, the team members will come. So what do we do, PI? What do we do here under these circumstances? Because looking up to the PI for leadership, and if you don't, you can go back to the protocol section this and give direction. If there are problems, there's some ambiguity, then the PI or the investigator will communicate with the medical monitor or medical supervisor appointed by the sponsor for clarity. And also, why we need to pay attention to the protocol is that in the event of a deviation, that is, you do things not in accordance with the protocol, it has implications for monitoring and if you get into an audit. That is one part we don't want to get into, deviations, major or minor, we don't want it. So the principal, the investigator is responsible for strict adherence or compliance to the protocol. So there are a number of issues here, and I will also talk through them. The investigational product is just the product you are testing in study. There are many times they are blinded. You don't even know which one is placebo, which one is the active product. They look the same. And what are the roles? there's usually, once there's an IP, there will be a pharmacist. So the pharmacist takes care of the receipt, storage, dispensing of that IP. But although it has been assigned to the pharmacist to handle that, the responsibility still falls on the PI. That is, if it wasn't properly stored or improperly dispensed, the sponsor, the monitors will speak to the PI. Randomization procedures and unblinding. Now things have changed. Technology helps us. There are usually more than one arms. It's called randomized control trials. Two or more arms. The ones that are receiving the active product or placebo, or receiving the new one, the new drug, or the new product to the comparator. Or you could even have 3 or 4 arms where there are multiple things being compared. And in that case, the participant does not choose. The investigator does not assign. They are randomly assigned to the arm they fall onto. These days we use the computer. It's just allocated. You don't need to do much. Unblinding, that is very critical. We don't usually unblind, but there are conditions under which we can unblind. For instance, if there's a severe adverse event, which could be attributed to the drug or medication being investigated, but you don't know whether the participant had the placebo or the active ingredient. But you need that information to be able to intervene correctly. So you can call for unblinding, pharmacists involved, the sponsors and the channel, and we unblind to do that. Informed consent for clinical trial participants, and that is the key. Informed consent. There's a process, it's a long process where you give the participant the opportunity to understand what the study is all about, give room to ask questions, and as was mentioned by Sister Puna, you could even give them time to go home and come back. There's no form of coercion there. And there's no disadvantage to the patient, the potential participant who declines to participate in that study. In fact, this is one area that you need to, the burden is on you to prove that this participant was not forced or coerced. There's no incitement whatsoever. It has to be properly documented that the informed consent process was followed according to guidelines. And this has a history. We know about the Tuskegee trials for syphilis and the Holocaust, where clinical trials, that's where those trials were started. People were just grabbed and treated, maltreated. Records and reports. Clinical trials, I don't know whether there are people here already thinking of coming into this. In this field, we write, we document. Not stories, but you need to document. If it is not written, it is not done. If it is not written, it is not done. And that can be the what keeps you away from being deregistered or being struck off the roll. Documentations. So we pay a lot of attention. Progress reports, I told you about communication between different regulatory bodies and the sponsor. So intermittently, maybe 6 monthly, yearly, give reports to the ethics committee, to SAPRA, to as many as has been indicated in the protocol that you give reports. Safety reporting, of course, if there's any adverse events, you need to report that appropriately and intervene. Premature termination or suspension of clinical trials. Not too long ago, I think that was last year, COVID brought a lot of issues. You can remember there was a time there was a pause on the J&J vaccine because of the adverse events that were coming up and they were not too sure. And there was a pause which affected us in South Africa during the Assemble project. And we had to stop, just wait and hope that things will go on. And it was changed. Also, some years ago, there was this trial about for HIV, where there was a gel that was protected, used to test whether it was preventive of HIV transmission among the commercial sex workers. And the preliminary data analysis showed that there was no protection. And that study was terminated because it would have been unethical to continue the study when there was more harm being done. So it was terminated. Those are some of the conditions under which you can prematurely terminate studies. Also, the good part of it, if there's overwhelming evidence that your drug is doing what you hypothesize that it will do, and there's good results, you can terminate it and continue. We also had that with the COVID vaccines, emergency use. There were preliminary results showed that it was effective and it was approved. The final report, you look forward to this as an investigator. Also, right, sign it off. And because as long as that study is there, there's a burden on your shoulder, there's a load on your shoulder. Just get it through. It takes time, it's not over months, days. Some months, it might take some months. You might have stopped recruitment in January and you're still doing the reports till June, depending on the study. All right, these are some of the references that were used, but I'm going to just give a summary, more or less like a take-home. For the investigator, there are two arms we should look at. They are the technical skills that is required of the investigator. Your qualification, your registration, and skills that you have acquired and experience. That cannot be taken away from you. And almost everybody will have that. But there are the soft skills which are very important that plays a role in the success or otherwise of the study. One, attention to detail. As an investigator, you must have that skill, attention to details. You can't just rush through things. If you do that, certain things will fall through the crack and it will be catastrophic. I talked about writing, documenting. That has saved us when it was documented. And areas where you make a mistake, you get called. I can't overemphasize that. It's a skill we need, ability to document. An investigator must also be available and responsive. You can't be there 24 hours, but as the PI or the investigator, the main investigator, you're not expected to be there every time. But when your attention is needed, you must be available. You must be reachable. For certain roles, no one else may be able to play them but you. Like one communicating with a medical monitor. If there's some ambiguity or there's some serious crisis during the trials affecting the participant, you need to communicate with the medical monitor. Dynamism in line with the protocol. And COVID taught us a lot. As was mentioned earlier, in the past, you had to come to the site. But with COVID and some issues, we were able to send teams to meet the participants at home. Another example was during the hard lockdown when people could not travel. We tried to ship the products, IPs, to participants outside our province. We won't try to send them to Zimbabwe for one of the studies. So those are some things we need to be able to adjust, amendable according to, but keeping in line with the protocol. Finance. The devil is in the detail. It is in the detail. You don't want to run a study and close shop because you have misappropriated the funds. Thank you for your attention.
Another round of applause, colleagues. Thank you very much, Dr. Fadan.
Yes,
Did I get it
you
right?
got it right. No,
Dr.
please.
Fadan is the principal investigator, epidemiologist, and a biostatistician at Cut-Crismo. We are really grateful for the information. This brings us to another session of question and answer session. Colleagues in the cloud, please do share your comments, your questions in our chat box. We will take the opportunity to respond to that as well. The floor is open for question and answer session. Dade?
Doctor, I'm very interested and I'm actually intrigued, but I'm also very excited. Back to my question, I need some clarity. Cut-Crismo, the role or the collaboration with CUT, the way I may be wrong or right, is that we start an investigation site in Bloemfontein. Am I correct on that?
Yes.
So you foresee that with in collaboration with CUT, and I think that's an excellent idea. I think the market is there, or the need is there. But that will, and now I'm thinking about the financing side, that will means there must be a PI here, study coordinator, registered nurse, pharmacist, data capturers, whatever. So you foresee that. I just want to say, or what I want to know is, we must not let this be a dream. We must put it into action, and we must. Do you foresee that just to get going, that these will be, for instance, the PI will be a physician that you just contract for the studies to be a PI? Or what do you foresee in that case? Because to set up a site, like, it can be a costly thing, because I mean, all the equipment, the fridges and the backup electricity and all of that. So I just think at some stage you need to put together some timeline on when what's going to happen, and then we must. That's my suggestion. We must go for it, because from my side, I'm very excited.
Okay. So I'll take that as a comment, but I'll also chip in something. There are a lot of things that are being planned. The timeline for the educational postgraduate diplomas and all that, looking at 2023, 2024. For the sites, here, no clear timelines have been set, but our model in Cut-Crismo is full-time, part-time, based on the needs at that time. So we could start with the part-time, or we could start with a full-time, depending on what is happening. I think earlier, the first presenter also mentioned that the idea is to have a site here in Bloemfontein. So the earlier that it happens, the better. Not just a site that is going to be just Cut-Crismo, but a collaborative site between CUT and Cut-Crismo. And from there we can.
Just make a comment there on the academic side. I think to get the academic, and there, I mean, my colleagues will know more than I do, but to get an academic qualification going take quite a few years, because it must be registered, it must go to SAQA and all of those. So that take quite a few years. But I think the site idea, we going as
yesterday. That's the feeling in Chrismo. Yeah, Queen, what we feel like yesterday. Thank you so much.
Another question from Prof. Frederick Nell.
Thank you for the three presentations. Just something that was said earlier, there's a lot of data and reports that who does the intellectual property belong to? Does it belong to the company who paid for the trial, and do they own the data? Or is it something that you say there are so many points that can be taken further?
We have rights to publish. That's with that. But I know with the university, for you to publish and be recognized as authors on that, the intellectual property must belong to the university. And I'm sure the legal team will look at that. On our side, the data, we have the right to publish from the data. Now, the legal team from CUT will need to discuss with the legal team from Crismo on sharing the intellectual property. Who does it belong to? Because I know very well in the universities, your name is there, the universities, you are affiliated to the university, and the university wants to own that data. So those are some legal, I'm not a lawyer, but I know those are things that the legal teams will talk about. Very good question.
Thank you, Prof. Frederick Nell, and thank you to colleagues from Crismo. We heard you. In Setswana, we would say, "Hara lutla ka sa kgamorakile," meaning that we heard every little thing that you said, every information that you have presented to us, it's been recorded. And like I said earlier, the challenge is upon us, that how do we take this initiative forward? It brings us to the end of our presentations, and we would like to request our acting dean, Professor Hester Frederick Nell, to come and give us closing remarks. Thank you very much.
Good afternoon from my side, ladies and gentlemen. Mine is a very fortunate and privileged task to do the closing on this very exciting event. You know, listening to all the discussions today really excites one, specifically the diversity of opportunities that we actually have at our doorstep. And not only for CUT, Faculty of Health and Environmental Sciences, but also for Crismo. And I think that is the beauty of collaboration. And today we have really maybe just scratched the surface to start to grow and nurture and develop our collaboration between Faculty of Health and Environmental Sciences and Crismo. And although baby steps, it doesn't matter. It is a small step in the right direction. And no baby step was ever for granted. So like they say in Africa, when you want to walk far, you walk together. So from the Faculty of Health and Environmental Sciences, I also want to again extend our sincere appreciation to Crismo for trusting us to be your partner in this very important process going forward. At CUT, we all live to Vision 2030, which means that, you know, we want to be the leading African university, and we also have a responsibility to our community and to bring our community together and to serve the community. And as we have discussed, that we should uplift the community to help them to understand their important role in participating in these kind of events. And I was still talking to Sister when I said my dream is that before I say goodbye to the academic world, that in the Faculty of Health and Environmental Sciences, we have a calendar to celebrate each month the different preventative and awareness campaigns. And maybe it's a small project that we can work on for 2023, or maybe even starting as soon as we can, because there's a lot of expertise in the Faculty of Health and Environmental Sciences, and we can even include our communications and marketing section, and we can really start flagging, although it's maybe not at the level that we want to collaborate, but it's giving us that lift off in nurturing our collaboration. So as I said, we are really fortunate to have this, this partnership, and not only to realize our dreams in the faculty, but also to realize the vision of the CUT. I want to commend both Prof. Makafula and the HOD, Dr. Mfingwana, the colleagues in the Center for Quality of Health and Living, as well as the colleagues from Cut-Crismo, which I say I must brag every time, because my dear Major is one of our recent graduates in the Advanced Diploma in Health Management program. And yes, it was during that time that Cut-Crismo also attained the Standard Bank award. And it was like, yes, look at what our alumni is doing. Yeah. So thank you very much to everybody who was involved in putting together this day. I know behind the scenes, there were many also during the day, Madam Program Director, those who participated, as well as the audience who were actively engaged in this discussion. And I hope that you are going away with a wealth of information, a world out there that is lying, waiting for us to further explore and to strengthen. So with those few words, I close this lovely event and say thank you to everybody. Thank you.
Thank you, Madam Dean. I want really Kisinye, the beauty that she had said. She said a mouthful. Thank you very much, and thank you for hosting us, Madam Dean. Thank you, Prof. Makafula and your team. This brings us to the end of our session. Thank you to those who are on cloud. We appreciate your participation as well. Thank you very much to everyone.